Welcome to the OAO Member Spotlight, your chance to get to know your colleagues in a new and engaging format. Each month, we highlight a member doing something unique and interesting, something you can take inspiration from and maybe even implement into your own practice. Sit back and enjoy the OAO Member Spotlight.
I'd like to welcome everybody back to the OAO Member Spotlight. This is our 10th Member Spotlight, and today's a first because we have 3 optometrists. We never had that before. I think our record before that was 2, so now we've got 3. They're from a group practice in Mississauga, Ontario. So we have Dr. Manny DeBono, Dr. Fallon Patel, and Dr. George Hanna. So welcome, guys, to the Member Spotlight. Manny, maybe I'll get you to kick off and introduce yourself.
Certainly. That's Dr. Manny DeBono. I'm the director and the primary original owner of the Mississauga Optometric Clinic, which is right in the heart of Mississauga. And we've been there for 33 years in the Sussex Center. And local graduate, local high school at Applewood Heights Secondary School. I graduated in '83 from the University of Waterloo. Did some work down at Northeastern State University to get the TMOD and prepare us for our advances in primary care.
Thanks, Manny. Fallon, do you want to introduce yourself?
Sure. Hi, everyone. I'm Fallon. So I graduated also from Waterloo not too long ago in 2011, and I've been practicing in Mississauga and Toronto for the past couple years here. And I started to get some special interest in vision therapy, and so I've been doing VT, in-office VT for about a couple years now, and I've been enjoying it.
Great. Thanks. George, over to you.
Hi, so George Hanna here. Graduated from Nova Southeastern University just a couple years ago, 2013. Moved on to Illinois College of Optometry to do a residency in primary care and ocular disease. Spent a lot of time managing diabetic retinopathy, glaucoma, neuro-ophthalmic disease, and that's really where my interest in dry eye began. Currently, I work also at the University of Waterloo as a clinical instructor, and I hope to use the skills and the things that I gained there to bring it to practice.
So Manny, over to you. You graduated maybe just a couple of years before I did. And when we graduated, everybody had a general optometric practice, but now you've made the move towards incorporating sort of niches or specialties within your practice. So can you tell me, why you've decided to go down that road?
As you know, the advancements in our opportunities as primary care practitioners has been escalated, and none of us can be experts at everything. And what I've found is that everyone also has a flair or a knack for various disciplines. And Fallon's excellent with young people and has a flair for teaching and her patients galore. And she's done all the extra work to get certified. George has done a residency, and of course is excellent with pathology, and he's going to head the dry eye sector of the practice. And granted, these are areas of growth that I think are paramount as we have children with needs and we have an aging population with needs, and this allows them to grow and get busy while allowing me to oversee that growth and actually continue to see the patients that I've fostered over the past 3 decades. The other thing that I enjoy too is the fact that within the realm of the practice itself, we can interrefer, we learn from each other, and we're always there to back each other up. It's been wonderful.
I guess you partially answered my next question. Why vision therapy in particular? Why dry eye? Was it because obviously you've got 2 young associates in your practice now, and they brought that with them, or did you actually think in the back of your mind, I want a vision therapy subspecialty in my clinic, I want a dry eye subspecialty in my clinic? How did that come about?
Well, as you know, I mean, we to reiterate, the aging population, the dry eye challenges, the computer syndrome, the fatigue syndrome. Dry eye is a big issue, but vision therapy is coming into its own, and is something that's absolutely dynamic and well suited to the profession that we have, working with children who've been labeled, who have learning disabilities, whose perception is not just limited or linked to a refractive error or some kind of asthenopia. So again, those two fit perfectly with our particular practice, and the fact that we do see a lot of people with pathology in the area, anyways.
So maybe I'll pass it over to Dr. Patel. So how did you gain knowledge and expertise in the vision therapy space?
All right. So vision therapy had kind of been something always at the back of my mind as a personal interest. So I've always had something, as you guys all know, convergence insufficiency. So this is a problem that I've suffered with my whole life, and so I've had problems with reading. I've never been a fast reader, and so I've had to work hard, to overcome this problem. And I never knew, that was the reason why I read slowly until optometry school. But even going through optometry school, I didn't really get a whole lot of training, how to fix CI. So I kind of just left it at the back of my mind for a bit until Dr. Petal, she held a recent, a couple years ago, she held the first ever CE in VT in Ontario, and so I attended that CE, and from attending that CE, I found out, there's so much more that we can do for our patients, and I had absolutely no idea. Like, it was just so flustered going to that first CE course that I thought I need to learn more. And so from that, I went down to the COVD, so there's the College of Vision Development, and they have annual meetings every year and courses that you can take. And I just invested myself in that. I took as many courses as I could possibly take in the past couple years, and I'm in the process of getting certified for a fellowship through that now. And so that's pretty much how that all just kind of tumbled upon me, and I've been getting, great satisfaction in helping patients, and so that's pretty much how I started and where I'm at now.
So a lot of time and energy and learning and courses, probably many weeks away from the practice, I would think.
Oh yes, I mean, I did 100 hours on my own just to get some knowledge in this, to feel comfortable with what I'm doing. There's lots of questions, so if you want to get certified in VT, which can really help you with your VT practice, they have lots of questions, open book questions, and final case questions that you can go through that it really helped me how to deal with patients in my practice. So without that training, I don't think I would be as good of a VT practitioner.
You touch a little bit upon sort of how much equipment that an optometrist might need to get started in a vision therapy or to incorporate vision therapy into their practice?
Sure. Equipment-wise, I mean, there's some websites that you can go to purchase equipment. So Burnell is one that you can go to. Goodlight is another website, and OEP also has some equipment on there. But when you go to these websites, I mean, the amount of stuff that you can purchase is really overwhelming, and you really don't need a whole lot when you're starting out in VT to incorporate that in your practice. So I would first purchase equipment based on what you feel comfortable treating. So let's say if you want to start treating amblyopia in your practice, or CI. So for amblyopia, you want to think of your treatment plan. So what is it, some things that I need to purchase for amblyopia? You might want to purchase some occluding fogging filter lenses for your practice for these patients. You might want to incorporate doing some depth perception or stereopsis exercises, so some vectograms or eccentric circles for these patients. Let's say for something like CI, we might want to train vergences. So you might then want to purchase some Brock strings, or you might want to incorporate a computer software program like HTS. You might want to then train accommodation, because vergence and accommodation are highly linked. So training one might better your results in the vergence issue, and stereopsis training. So it really depends on what you feel comfortable treating and your treatment plan. So I'd purchase equipment based on what you feel that you're going to treat. And then slowly, as you get more comfortable with it and you want to, start treating things like strabismus or traumatic brain injuries, then you can further, purchase equipment down the road for that.
Okay, so if you were to start dabbling in vision therapy, take a very conservative approach, like start with CI, amblyopia, you're talking what, like maybe under $2,000, under $5,000, just a ballpark.
Oh yeah, so that can be much less. So like if you're thinking about amblyopia or CI, you can invest maybe $500 to $1,000 worth of equipment, yeah. And then based on your results and how you feel your patient is progressing, you might want to look into purchasing something else down the road. But that's a really good ballpark. I'd say about 2,000, yeah, and under.
Now, what about marketing? So you've done all this training, you bought the equipment. How do you start to get patients? Do you just generate that internally from the other optometrists in your office, or have you done some external marketing? Can you maybe touch on how you've started to build that part of the practice?
So a bit of both. So I first started out with just internally marketing. So within the group practices that I'm in, I told all the doctors, this is what I'm going to do. This is what I feel comfortable treating. So if you see any patients that have these problems, you can come and see me or refer them to me. And then externally, yeah, I've gone out into my community. You can go out to places like Montessori's or private tutoring companies just to kind of drop off some flyers to let them know that these problems exist. So if patients have reading difficulties, to come get a vision assessment or even an eye exam, really. And for, let's say, treating traumatic brain injuries, I've gone out to physiotherapists in the area and occupational therapists in the area, and these are great referral sources as well.
Awesome. Okay, so George, Dr. Hanna, maybe I'll pass it over to you now. You're the ocular surface guy. You're the dry eye guy. How did you gain knowledge or expertise in the dry eye space?
Well, it's kind of similar to Fallon. It wasn't something that I have wanted to do ever since I was younger or anything, but it started during my residency training. It really was after a talk that Paul Karpecki had given, and of course he's a big dry eye ocular surface disease guy, and it was inspiring, and it made me want to look more into it. And as I gained some clinical experience, I really noticed how much ocular surface disease really exists out there. We may not get, there may not be as many people who admit to it or present with a chief complaint, but I realize as the more you ask patients, the more you realize that there's a lot of, dry eye, meibomian band dysfunction that's just left out there untreated and unmanaged, just simply because we don't ask the right questions. So over time, with my experience, just seeing how much it's out there, it's really, it's inspired and motivated me to learn more. With that said, I've spent a lot of time reading on the studies and listening to lectures, and I also work with Lisa Prokopich over at the University of Waterloo, who's also a big dry eye person. So it's been a good journey. It's still got a long way to go, but I'm excited to get it going at the clinic.
So same question I asked Fallon Patel. How, marketing-wise, you've got an interest in this. You've gained extra knowledge. How do you start to build that practice? Again, maybe answer it in two parts. So within the practice, internally, and then externally.
So similar to Dr. Patel, we can all treat dry eye, but sometimes it does take a little bit of extra effort, a little bit of extra testing that maybe can't be done throughout a regular, your comprehensive annual eye exam. So just letting the partners know that that's my interest, and moving forward and getting some extra things in the clinic, which hasn't started yet, but hopefully will be soon. That's how we're planning to do it internally. As for externally, it's really a matter of going out speaking to local family practices, local specialists in the area, not just eye specialists, but just general medicine specialists who deal with a lot of patients who are on oral medications that cause lots of dry eyes, rheumatologists, family practice. So just going out and telling them that we do exist in the area, and hopefully that's going to send in some patients to build a clinic.
Okay, thanks. Manny, maybe we'll turn it back to you. You've brought two keen young optometrists into your practice. Mm-hmm. What sort of adjustments have you made, as a practice owner and workflow-wise? A lot of these patients will need, different lengths of appointments than a regular eye examination. They'll need quicker follow-ups. They'll need longer assessments. How have you adjusted sort of the workflow in your practice now that you're starting to add this?
Well, being new to the practice within the last year or so, both Dr. Patel and Dr. Hanna can govern their time within the clinic as they see fit, whether it's based solely on seeing exams, pathology, or doing vision training. To augment the answers that they had going forward, we have the facility's been newly revamped, including websites, and part of the growth program is to make sure that the vision therapy and the dry eye facility are part and parcel of what's on the website, added in with the Google words, and they're both technologically sound, and they can grow from there, as well as through local practitioners and whether it's GPs or other optometries or other specialties, as they get the confidence to continue to go forward. So it's just in its nascent stages, but again, it's really quite interesting. In Dr. Patel's situation. Even though the clinic has really been revamped and is new in its internal workings, I can see it won't be long before we're going to have to dedicate a room to vision therapy and allow her to use her exam room to examine other patients. Other than that, in terms of fees and allocations, we have sampled our contemporaries and spoken to pharmaceutical people who are aware of, like, dry eye clinics, for instance, out in BC and Alberta, and they have a fee schedule out there. So without taking up too much of anybody's time or infringing on their personal fee schedules, we've been able to come to a reasonable facsimile of where we want to be. And of course, time will dictate whether we're charging too little or too late, and we'll adjust it accordingly. But I know there'll be nothing but top level care being provided at this facility.
Yeah, because it's always tough. You want to charge a price that's fair to the patient, but also profitable for the practice. And I think optometrists have a lot of value to add in this space because no one's really paying attention to this. And there's patients out there that are in desperate need of our services. So,
well, I totally concur. And getting the news out there is really the critical component, and especially with people who are suffering, whether it's vision therapy for children who are having problems learning, or people who are chronically abusing themselves using concoctions in the eyes. Like, they're willing to pay reasonable amount of money for good care, but if we tend to err usually on the side of being minimalists, and again, time will dictate where we need to be, but again, our primary concern is to make sure we're doing it and doing it well.
Exactly. So one more question. It's going to be the same question. First I'll ask Dr. Patel, then I'll ask Dr. Hanna. As you're starting down this specialty niche road, Dr. Patel, what's sort of one thing that you would, knowing what you know now, what's one thing that you would maybe do differently over the past year or so as you've started this?
Well, I was warned ahead of time before diving into this, was to make sure that I had a therapist trained right away in space. So spacing, thank God I have, but the therapist, it's probably easy to get one on board, as early as you start on, because it's tough finding, a good therapist. So that's one thing I would have changed. I would have started earlier to find one.
So you were the doctor, the assessor, and the therapist in the beginning.
Correct. Yes. So in the beginning, I wanted to make sure I did all the therapies myself, just so that if I'm training someone, I'm able to answer those questions, those tough questions. I mean, patients have hard questions that they ask you. Why are we doing this? How is this helping me? So you want to be able to make sure you've gone through everything and all the different types of patients that you're treating before you start training someone. But I wish I kind of maybe had someone in there before just to shadow me. It might have been a little bit easier. Because then all of a sudden you kind of get backlogged and you're trying to find someone, and it just becomes a little bit tougher to kind of manage down the road. So. Okay,
that's great insight. Thanks for sharing that.
Mm-hmm.
Dr. Hanna, over to you. What, knowing what you know now, what would you do? One thing that you would do differently?
I think it's something that's really simple, but could help the practice grow a lot, which is just basically ask the right questions to the patient and screen every single patient who walks through that door. Every day I'm surprised by how many people have issues that they just don't tell you about, simply because we're not asking the right questions. So if anything, maybe whether it's giving a questionnaire to every single patient who walks in, or just making sure to ask 3 or 4 specific questions to ocular surface disease, that's something that I wish I would have done more often. It probably could have helped build this a little bit quicker, but we're still fresh, it's still young, and we got time to go, so I'm excited to keep it.
Okay. Thanks, guys. I really appreciate you coming on to the Member Spotlight. I think group practices are definitely the wave of the future, and I think specialties within those group practices are just a natural evolution of the profession. I think you've got lots of bases covered within your practice, so the patients, no matter what their needs are going to get great care in your office. So thanks again for taking time to be with me tonight and sharing this with your colleagues.
Thanks, Jeff or Dr. Goodhue, for the opportunity, and thanks for putting the time out, Fallon and George. And these guys are great.
Thanks, everybody.